I wanted to point out this recent publication, a clinical trial conducted by the Zhongshan Alliance for Biliary Tract Cancer for resectable high-risk intrahepatic cholangiocarcinoma, a phase 2-3 study of 178 patients that were randomized to what's called the GULP regimen, which is gemcitabine, oxaliplatin, toripalimab, and lenvatinib for 9 weeks neoadjuvantly, and then on to surgery versus control, where they just went straight to surgery without neoadjuvant. Well, staying on the theme of neoadjuvant therapy and immunotherapy, but for a disease that we've not seen this before, intrahepatic cholangiocarcinoma. This is a case of a 50-year-old woman with an incidental liver mass and a biopsy-confirmed adenocarcinoma consistent with an intrahepatic cholangiocarcinoma. She did not have any underlying liver disease and no prior history of malignancy. She did have a family history of endometrial and colon cancer. Her metastatic workup was negative and her CA19-9 was normal. Of note, this tumor is basically impinging pretty significantly on the IVC. And so this would be a wonderful case for neoadjuvant therapy, which really very little was known about for cholangiocarcinoma, but I wanted to point out this recent publication, a clinical trial conducted by the Zhongshan Alliance for Biliary Tract Cancer for resectable high-risk intrahepatic cholangiocarcinoma, a phase 2-3 study of 178 patients that were randomized to what's called the GULP regimen, which is gemcitabine, oxaliplatin, toripalimab, and lenvatinib for 9 weeks neoadjuvantly, and then on to surgery versus control, where they just went straight to surgery without neoadjuvant. Median follow-up, as you can see, of 16.9 months. These are the results. The median event-free survival was statistically significant, 18 months for the neoadjuvant GULP arm versus control, 8.7 months. The overall survival at 24 months had a p-value of 0.005, with 79% patients surviving at 24 months in the neoadjuvant arm, compared to 61% in the control arm. However, this did not meet the pretrial criteria used for statistical significance of 0.001. And so in this report, the overall survival was not reported as statistically significant. The adverse events were not terribly significant. As a matter of fact, surgical complications were not higher in the group that received neoadjuvant GULP. So this is the study schema. Patients that were eligible were randomized, and they either received the neoadjuvant therapy, then surgical resection, followed by adjuvant capecitabine via the BILCAP study results, versus the control group who went straight to surgery. In the neoadjuvant GULP group, eligibility was that they had to have biopsy confirmation of IHC. And that was after the first 2 patients, because this was not a requirement initially, but it turns out that the first 2 patients ended up not having IHC at time of resection, and so this became a requirement. They had to have class A cirrhosis, and they had to have high-risk tumors defined by what you see there: a large tumor, vascular invasion, multiple tumors, regional node metastasis, or an elevated CA19-9. And importantly, it had to be resectable. The event-free survival curve is shown on the right there, and that is statistically significant. For those that were randomized to the neoadjuvant arm, the objective response rate was 55%, and the major pathologic response rate was 19%. And you can see that those that had either a major pathologic response or a response did better than those who did not. So back to our case study, really it comes down to, would this patient have been eligible for this clinical study, or do those study results apply to this patient? And the tumor is large, CA19-9 is normal. Just by having a large tumor, it would be defined as high risk. However, the question is it resectable? Well, it turns out this study this case that I'm showing you was from about 10 years ago. There were no neoadjuvant therapies there. We ended up resecting this by going under veno bypass and resecting a portion of the IVC and replacing it. The patient did recur soon thereafter behind the IVC. Nevertheless, this shows that this paradigm shift of neoadjuvant therapy now is applicable to cholangiocarcinoma with use of immunotherapy combined with chemotherapy.